Kim, do you hear me?
Yes. Can you hear us?
Yes,
Okay.
yes, very good.
Welcome to SNUH Hospital. I prepared the second TAVI case. My co-operator is Dr. J.Q. Han and Dr. Doyeon Hwang and Dr. Karam Nang, anesthesiologist.
Professor Kim, we can see you.
Now we can see. Okay, go ahead.
Okay, slide please. 저쪽에서 말을 못 하던데. 슬라이드 플리즈. 이기원 선생이 잘해야 될 거라마. Okay, I prepared a TAVI-in-TAVI case because nowadays Korean history of TAVI is about 12 years. Thus, there occur some cases of TAVI valve failure. I prepared a core valve failure case that will be treated by a SAPIEN plus 81 years old female, complaint dyspnea, admitted to another hospital because of acute heart failure. I deployed core valve 26 millimeter 8 years ago for bicuspid severe AS and consistently normal on follow-up echo, except for trivial paravalvular regurgitation until last year. But suddenly she developed moderate to severe transvalvular regurgitation. Plus, no comorbid condition. Issue is a bicuspid aortic valve with severe AS was treated with TAVI using core valve 26 millimeter 8 years ago. At that time, she had dilated ascending aortopathy, but there was no change of diameter for 8 years. 49 8 years ago, 49 today, plus. She underwent DAPT prescription for 8 years. Thus, she does not have any leaflet thickening or valve frame thrombosis. Target is degenerated TAVI valve with transvalvular regurgitation. I plan TAVI-in-TAVI. Plus, borderline cardiomegaly. She once experienced heart failure last month. Sinus rhythm with LBBB. Plus, T, we can see severe regurgitation focused on non or right coronary cusp. It is not paravalvular, it is transvalvular. Plus, 8 years ago, I treated her by severe AS using core valve implantation. Without any happening, well finished. Plus, under expanded frame was expanded by post-ballooning, and final angio shows a little bit deep implantation, but no problem because there is no AV block and mild paravalvular leakage. At that time, that was acceptable using core valve without Evolut Pro, without any outside skirt. Plus, after TAVI 8 years ago, the paravalvular leakage was observed in pinpoint at 2 o'clock. So that was not transvalvular. That was mild paravalvular leakage. Plus, and now we prepared TAVI-in-TAVI. Another issue is very tortuous aorta. So we have to straighten it without any damage. Plus, actual core valve 26 millimeter diameter at annulus is 22 millimeter. 26 is diameter at the bottom of valve. Actual waist is 22 millimeter. That corresponds to 23 SAPIEN valve. Plus, here once again, good news is wide sinus space, left side on the right side. Thus, coronary obstruction, especially in TAVI-in-TAVI, is an issue, but no problem in this case. Plus, coronary ostium height is good enough. When you measure coronary ostium from the bottom of valve, it is about 24. Thus, regarding considering 8 millimeter ventricular depth, actual supraannular costia ostia is about 16 millimeter. It is good enough with wide sinus. Plus wide sinus on the left and right. There's no chance of coronary obstruction, even TAVI-in-TAVI situation. Plus, regarding best projection angle, we use previous core valve as a landmark to implant sapien valve. Thus, we adopt right side projection angle based on core valve parallax view. Plus, to summarize measurement, actual diameter of failed core valve at annulus level is 22 millimeter. As the junction height is tall enough, thus there is less chance of SD junction isolation in TAVI-in-TAVI. Plus, annulus area is 370. That corresponds to sapien 23 millimeter valve with 10% oversizing with nominal inflation. I use nominal volume, achieve 10% oversizing. Plus, I prepared the 4 issues for this case. Long-term clinical outcome after TAVI of bicuspid AS. Fate of arthropathy in bicuspid AS after TAVI. Durability of TAVI valve. Final technical points. How to optimize position of sapien in the failed core valve. Plus, long-term clinical outcomes after TAVI of bicuspid AS, good, as TAVI of tricuspid. All-cause death, stroke is similar to each other, no problem. Plus, fate of arthropathy. Most physicians, surgeons believe that arthropathy is a contraindication of TAVI and absolute indication of surgery, but that's not true. For this case, 49 8 years ago, 49 today. No change after TAVI because eccentric jack disappeared after TAVI implantation, leading to slow laminar flow. Thus, there is no further dilatation of aorta. 49, 49, 48, 50, 51, 49, 49. No change. Don't be afraid of arthropathy. Plus, third, durability. This is Notion 8 years follow-up results. Structural valve deterioration on the left side. TAVI is better. Final valve failure at 8 years, about 5%. Similar to each other. Thus, these patients are included in this 5%. Okay, plus. Another point of durability is leaflet thickening or thrombosis. This small study checked the valve leaflet thrombosis instance under edoxaban or DAPT. At 6 months, instance is very high, about 18% under DAPT. But I believe this is too high. Plus, actually, this patient has not halt under DAPT, even for 8 years. So I strongly recommend DAPT rather than aspirin single agent if patients tolerate. Plus, the final issue is technical point, optimal positioning of sapien 3 in the failed core valve. Plus, you have to understand the measurement of left core valve 26 on the right, sapien 23. On the left side, important thing is A diameter, actually 26. But B, functioning valve level, internal diameter is about 22. The other issue is height F and height E. F is outside skirt. That is 12 millimeter. E is commissural height, 26 millimeter. E minus F is 14 millimeter. That is the level, zone of functioning core valve leaflet. That is target of our sapien. On the right side, A, sapien total height is 18 millimeter. Outside skirt is 9 millimeter. Thus half of the bottom is has skirt. on the left side core valve, this patient's intraventricular depth is about 8 millimeter. Thus, we are going to target SAPIEN on the 8 millimeter from the bottom of core valve. Then we can cover the functioning core valve leaflet. Plus, this is an important tip to do a SAPIEN for failed core valve. On the center, if we implant SAPIEN a little bit lower, S3 outflow at nodal 4, we can guarantee a kind of wider valve area. But the problem is on the left side, the functioning core valve leaflet is overhanging on the new SAPIEN valve inside. But that is not a significant problem. If we implant a lower position, leaflet overhanging may be an issue. If we implant a little bit high, S3 outflow at nodal 6, the problem is nail skirt height is very long. So there is chance of S3 junction isolation and disturbance, impairment of coronary flow. Another point is when we implant high, we don't have to forget about change of radius of index evolute. That is increased by 1 or 2 millimeters, may endanger coronary flow. Plus, thus, to summarize this case, TAVI-in-TAVI, SAPIEN 3 Ultra 23 millimeter valve in the failed core valve 26. Technical excellence is very required. Okay, I can show you the process that we took today. Angio, please. 이기환 선생, angio, okay. Plus, we performed the rotarography. The valve looks fine. Ventral depth is about 8 millimeters plus. So this is a good projection to make the bottom of core valve as a single line. So that is a landmark for the implantation of SAPIEN valve. Plus, so we straighten the tortuous kinked abdominal aorta, and then we advance plus shift. Plus, then we inserted a wire into LV plus, like this, plus. We rotate the image to confirm the catheter is just center plus. Okay, is it final?
네.
Okay. Then we check the double tracing physiologic study 좀 보여줄까요? Pressure profile. 이규환 선생. Okay. As you can see, the pressure gradient between two chambers is not great, but we observed diastolic phase is very wide pulse pressure. And diastolic pressure in LV and aorta is very similar, severe regurgitation. This is the process that we took today. Then we are going to move forward.
Okay, nice job. And thank you for your kind introduction. When the patient has a left bundle branch block,
Immediately after core valve implantation, 8 years ago.
oh, I see. Any other comments or question from the panel?
So this is Hyung Dong-guk from Hanyang University. So do you have any data regarding the coronary angiography?
No?
Because in this case, we are planning to do the TAVR-in-TAVR with the balloon expandable valve in the self-expandable valve with the size of 23 millimeters, so which means that we have very high risk of the patient process mismatch after the procedure. So if we have the coronary angiography, and coronary angiography was just fine, and considering her age of 81, so we maybe choose the self-expandable valve into the self-expandable valve, I think.
Yeah, everything core valve, I don't like it because of the long narrow skirt or really impossible coronary accessibility. 23 millimeter Sapien is well deployed in the novo case. 20 is a high chance of PPM, but 23 millimeter valve in 81 years old female, I don't think that is a problem of PPM. Okay.
She may live till 100 years old.
Huh? 뭐라고?
No, just go ahead. Any comment?
Dr. Kim, you showed us
그 위치.
acrodio
위치.
TAVI device.
그래 올리셔야 돼.
Is it possible to use acrodio for this case?
Would you please say once again?
Yeah, you showed us acrodio device in the morning. So is it possible to use acrodio for this case?
Until now, the Boston Scientific do not recommend acute neo in this case, valve-in-valve procedure. But technically, I think it is possible to do a valve-in-valve procedure. Okay, I'm going to move the frame. 저장하고요.
Dr. Otsuchi Sensei, how is the TAVI in Japan?
Yeah, in Japan,
Okay.
we cannot do
LAO.
TAVI-in-TAVI. Just we didn't approve
자, 들어갈게요.
TAVI-in-TAVI.
Why stay?
So I'm very interested in TAVI-in-TAVI. How to decide the position of the second valve in this core valve.
자, 노멀로 한번 해줄까?
Dr. Kim just calculated the location of the Sapien valve, just the bottom of the self-expanding 8 millimeter above the scot.
Like this?
That's the target.
How about? Good?
Looking good.
Just 8 millimeter above the bottom of
Right.
core valve. I just withdraw the pigtail. How about this?
So particularly in this case, maybe the height is more important than the depth, considering that the slightly deeply implantation of the previous valve. So we maybe see the
It's good?
proximal margin of the stand valve when deploying.
Oh, cool.
I think that's the one of the good point.
밸브가 마크에 약간 올라가 있습니다.
So
벌룬보다 약간 올라가 있습니다.
Okay. It's good position. How do you think about?
that's
저장하고요.
good. Everybody agree? This location?
Just for your convenience, for your reference, we are going to do 좀 제대로 하지. angio here. 자, angio 준비. Sure. How about? Good? OS. Okay. Perfect.
Good.
Okay, pacing on. Inflation.
그래서 하나, 둘, 셋, 넷,
Four.
다섯 끝까지 갑니다.
Deflation. 자, Y 스테이 하고요. Y 스테이. 엔저 준비. 좀 빼고. 오케이. 오케이. 자, 스탠드 준비. 저장하고. I think it is good. We are going to remove the delivery system because I think there is no on the expanded frame. Just rotate. We have to see the on the expanded frame. 약간 아래어 커버. Okay.
何もしてないです。実際コメントもしないと思います。
Do you think we need post ballooning or just stop the ballooning? Previously, there is issue of ppm, fear of ppm. Thus, if we need once again or a little bit over just 0.5 cc over inflation. 어떻게 생각하지? 괜찮나? 오케이. 조금 더 expand 한다 해가지고 문제가 될까?
Yeah, will you check the echo or
오케이,
or
TT.
not?
TT.
Maybe left catheter.
No, what I mean is there is no chance of parallel leakage because there's tight opposition between two valves, inner sapien, outside core valve. But regarding the orifice area, I'm concerned about. So I try to expand further if it is possible without any risk. Do you see the echo? 이기현 씨 에코도 빨리 바꿔줘야지.
에코
Any comment?
Pulse pressure is very good. Okay, echo. Cross-section image. For the clear echo, I requested general anesthesia, but because of short time interval between second, third demonstration, thus we decide to do MAC. Okay, I can't see any significant probable leakage. But for fun, how about oversize index when we add 0.5 cc? 12.5% oversizing? Okay, just 0.3 cc over. For your fun, I show you the post ballooning with additional 0.3 cc to expand frame further to get enough orifice area.
Point to 2cc
아니요, 손안
is
필요합니다.
enough
Point-
for
네.
overexpansion
네,
in TAVI-in-TAVI.
0.3 cc
아,
reaches
네.
oversize index.
네, 지금 하는 거는 손 보여주세요. 지금
다시, this. Oversize index up to 13%.
좀 이따가요.
It is a very high value in terms of Sapien 3 Ultra.
다시
Just
이
why
화면에
stay?
바꿔주세요. 네,
Perform once
네,
again the
요거
ballooning
요거 메인. 네.
to see any significant change of valve
아니요,
area.
요거 볼 거예요. 요거.
We cannot see the. Okay.
Okay, rapid pacing. Inflation,
Deflation.
deflation. Pacing off. 저장하고요. 자, YSD하고 뺄까요? Do you feel any change with additional overinflation?
With my eye, no change.
No change. Okay. But on the left side, the border became smoother. Okay, I will show you once again the root arterography stiff wire in situ. Okay. 자, 쓰네 준비. Shoot. Okay, good. Then we are going to remove the system and exchange the wire into pigtail catheter.
Yeah, I think that
잠깐만요.
AR is
Why
due
stay?
to the wire bias.
마이너스 계속 틀어줘야지. 응? The beauty of TAVI is there is no chance of aggravation of AV block because previous valve protect the conduction system. Okay. 자, 플러시 합니다. 됐어요. 혈압을 조금 낮춰도 될 것 같은데. 예. There is a deep inspiration and expression. Thus, there is alternating pressure profiles.
But it's better than previous dual monitor.
140, 105, 79, 20. AR index is wonderful, but new index is 4.6, meaning no regurgitation. So we proposed in the world by publication JACC intervention a new AR index that is adopt the dichrotic notch pressure because actual diastolic regurgitation occurs between dichrotic notch and end diastole of aortic pressure. Thus, we use the dichrotic notch pressure. In this case, when I call the pressure, this is inconvenient in math because patient's respiration is very deep. 140, 99, 70, 22. I called 5 pressure points. And now the new index is 4.1. traditional index is 34. So traditional index more than 30, no regurgitation. New index more than 4, no regurgitation. Then we are going to show you the root arterography.
So Hyo-Soo Kim, we're gonna come back to you after BK's CTO procedure, 10 minutes later. Dr. Kim, BK, will you show us your case? BK, do you hear me?
촬영하고 있어.
아, 갔다 오겠다 소리도 없이 끊어버렸네. 가버렸네.
간단히 얘기했습니다.
I told you,
아, 내가 지금
you cannot hear my voice.
이게 떨어졌나?
BK, change to SNU.
Okay. Yeah. Can you see the angio? I show you the review. This is the inflation moment. You can see when we inflate the sapien, the major change of motion is shortening from the bottom. At the first, I target 1.5.
Will you change the screen to SNU?
Yeah.
Okay, now we can see.
At the before inflation, we can see the bottom of sapien corresponds to 1.5 node of core valve. Then after inflation, the bottom of sapien is shortened to the 2 or 2.5 node. Thus, I expect two node landing, but it is a little bit higher, 0.5 node upward because of shortening of sapien valve during inflation from the bottom. Plus, so this is the angio immediate after valve implantation. A little bit leakage, probably due to transvalvular, due to in situ stiff wire. Plus, not because of leakage, but because of future orifice area, we checked on the expansion of valve frame a little bit on the left side. Plus, thus we performed a post-ballooning with 0.3 cc addition, leading to oversizing index 13.8, really highest index for Sapien 3 Ultra. They usually recommend 5% oversizing, but we performed about 14% oversizing to expand furthermore to guarantee as widest orifice area as possible. Plus, this is angio after post-ballooning, a little bit wider. Plus, this angio after removal of catheter from the ventricle, no leakage. Usually, with TAVI, beauty is no leakage, no further aggravation of AV block. Plus, another view, no leakage. Thus, we checked once again the frame. Plus, arteriocaudal view, we can see the under-expanded frame, but now the frame is well expanded to guarantee as wide orifice area as possible. Is there any comment from the question? Okay, let me show you the TE. 에코 보여줄까요? TTE. There's no regurgitation, paravalvular, transvalvular, TTE. 에코 좀 보여주라는 이기환 선생님. This is TTE after post-ballooning.
해놨어, 다 해놨어.
다시 angio. I expect increased number of TAVI failure case, which would be the second valve, depending on the first valve. In the failure case of valvulate, I prefer SAPIEN. In case of SAPIEN failure case, I definitely prefer valvulate, or in the future, actually NEO 2. For surgical valve failure, surgical valve is very similar to SAPIEN. It is an intraannular structure. Valve function valve is intraannular, short height. Thus, such kind of valve should be treated with valvulate. SAPIEN in SAPIEN, I don't think it is good because of the narrow orifice area or kind of risk of a tear if we expand further. Valvulate in valvulate, I don't think it is good because of the totally impossible future coronary accessibility and long, depending on the level, a long outside skirt. On the third case, I show you SAPIEN failure case that will be treated by Valvulate Pro. 화면을 이렇게 하지 말고 엔지오는 계속 보여줘야죠. 마이너스 엔지오. So if you do TAVI-in-TAVI using SAPIEN, please remember the shortening happens at the bottom, from the bottom of SAPIEN. Thus, it is safer to make the landmark on the upper frame of SAPIEN because upper frame movement is minimal, while lower bottom frame is shortened and moved upward. But in this case, core valve structure is really difficult to decipher. So it is easier for us to count node from the bottom.
Very good point, Dr. Kim. And congratulate for your successful case. Very nice, good job. So you want to
Thank
show
you.
another image or you just finish?
Another image, what kind of image? Okay, just
Okay.
minus, minus, minus. Times are left, minus, 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 minus. Initial regurgitation.
So this is the, I think this is very educational
Minus.
case for TAVI-in-TAVI, and especially the shortening of the distal SAPIEN. Yes, we should know that for our clinical practice as well.
그 마이너스, 마이너스 하면 파이널 이미지 나오지. 마이너스.
Any comment
Okay.
for the TAVI-in-TAVI, this case? Jimbe?
Dr. Hyo-Soo, this is Jim Bailey. For the second valve, standard position is original annular line or second valve position. I mean, some valve is too low or optimal position or too high sometimes. So first valve position affect second valve position or not. Your standpoint is original anatomy or first valve level.
Yeah, that is a good point. When we perform a TAVI-in-TAVI or VIV TAVI, the landmark should be the failed valve, not original annulus. Forget about original annulus. The target of our second TAVI is the functioning valve level of the first failed valve. Thus, I targeted the zone of functioning core valve zone. That well corresponds to the SAPIEN valve we implanted. Let's forget about original annulus level. Just remember new annulus, new functioning valve zone. That is different from failed SAPIEN versus failed core valve. Core valve is supraannular design, so functioning valve level is always higher than the original SAPIEN failed case. Thus, we believe previous study, E and A, the difference is about 12 millimeter zone of functioning valve. That is our new target.
Okay, last question.
So as far as I'm concerned, this is the very educational case that in this era of TAVI with the young patients, so we may encounter many of cases like this. So maybe this is the time for us to discuss about the lifetime TAVI management. What should be the first TAVI device? So as you mentioned, if we do the first TAVI with the Edward valve, so second valve strategy is very, very simple. So maybe we can discuss about this.
Yeah, that is a really wonderful question. The indication extends toward the younger patients. That's which should be the first valve. I prefer SAPIEN because considering the future accessibility of coronary artery, but in terms of thrombosis and orifice area, SAPIEN is not good for the self-expand valve, Evolut or accurate Neo2. But in terms of the valve-in-valve, TAVI-in-TAVI procedure in the future, then once again, SAPIEN is more preferable. Thus, personally, my choice for younger patients is SAPIEN, the biggest SAPIEN, and then failed Evolut or accurate Neo. Accurate Neo, self-expandable, wide orifice area with good coronary accessibility. Thus, in terms of this point, accurate Neo may be the first valve for younger patients because it guarantees wide orifice area, less thrombogenicity, and easy coronary accessibility.
Okay, thank you very much, Hyo-Soo Kim. Nice job.
Okay, see
Thank
you tomorrow later.